score for instructional praxis, which we call CLOX-2. CLOX is graded on a 15-point rubric. High scores are perfect, right? And so 15 is the best you can do. Here's an 82-year-old retiree with an exit normal for young adults, a normal mini-mental. She can draw a clock from scratch, which leads to the CLOX-1 rating. She can copy the examiner's clock, which is much less executively demanding and basically separates out the drawing performance. And she can do pentagons. And this little essential tremor that she has doesn't affect her scoring at all. Okay, this is Alzheimer's disease, a neocortical brain disease that affects the frontal lobes. So she has executive impairment, but also parietal lobes significantly, which means he has visual spatial impairment. He can't copy a pentagon. The mini-mental easily detects him as a case. His exit score here, like the man in video, would be about the average for dementia-specific care units in return. But this is what we're missing. This is type 2 dementia. This is just a medical patient with cardiovascular disease, cardiovascular risk factors. His mini-mental is normal because there is no brain disease in the neocortex. But his frontal circuit has been destroyed by the subcortical ischemic and white matter changes that he's got. He can't draw a clock from scratch, but he can copy one fine, and he can do pentagons too. So basically, these are the sorts of cases that we find really throughout clinical medicine of examples of type 2 dementias where the disease or the medications used to treat the disease is compromising their executive function, probably through effects on the frontal circuit function. This ability of the CLOX to distinguish a frontal circuit lesion from parietal lobes means that it's useful in discriminating different dementia types at the bedside rapidly in just a few minutes. So if you map CLOX-1 against CLOX-2, CLOX-1 here is the executive measure. My scores are good. We have set its cut point at the 5th percentile for young adults. So 10 out of 50 is the 5th percentile on CLOX-1. CLOX-2 is the drawing or copying task, and 12 out of 15 is the 5th percentile for young adults. So if you map to this box, you would essentially be performing at a young adult's level in both executive function and visual spatial praxis. But if you're in this box, you failed both a visual spatial measure and an executive measure, and there are relatively few conditions that can achieve that. One might be multiple cortical infarcts, if one of them happens to affect the frontal lobe, which is rare, and another one the right parietal lobe, for example. But another one is Alzheimer's that affects both the frontal lobe and the parietal lobe simultaneously. This regression line is for Alzheimer's cases in our clinic. So basically, this box defines type 1 dementia, and Alzheimer's patients generally fit that classification. But here are vascular cases. They don't follow the same regression. They have far more executive impairment when they have visual spatial problems. And so CLOX, the 2-minute bedside measure, can discriminate these two groups from a third group, which is normal level. So all three groups with about 78% correct classification relative to full dementia workups. But this is a 2-minute test that your medical student or nurse, we have our nurses doing CLOX as a vital sign in clinic because it reveals to the primary care doctor right up front whether the patient has issues with executive impairment and what kind of dementia type they have. There are a lot of clock drawing tests out there, and they vary in some pretty seemingly relatively minor things. But these relatively minor differences greatly affect whether the clock drawing task is sensitive to executive impairment or not. I think that there's a misperception out there that clock drawing somehow inherently measures executive function, and actually that's not what our data has shown. And people even cite our papers to show that their clock drawing test must measure executive function. But what our paper actually showed is that CLOX is far more likely to be associated with executive function than any of the other systems in this particular study. This is a backward stepwise regression model of the exit score as a function of 6 different clock drawing systems. And what the model is doing is kicking them out relative to their executiveness or their lack of executiveness. So Shulman's method was the least able to predict executive function. Then Sunderland below, and there's Meadows, CLOX-2, and finally CLOX-1 was the only one left in the model at the end of this process. change levels of care over time. And then we've been building models of their functional status and level of care and the slopes of those over time. So basically, here is a model of Wisconsin card sort categories achieved at baseline in the cohort, 192 cases. CLOX, this is a multivariate model. CLOX, the exit verbal fluency, enter the model, and trails B, enter the model, but what it contributes significantly to code 3. Here's what the raw means look like. This is the basically the scores, the mean scores of each category achieved in Wisconsin card sort, ranging from 0, which is terrible performance, to 5, which is relatively good. So what you can see is that the exit here is positively scored. The scores get higher as performance in Wisconsin card sort deteriorates. Here's CLOX, it's negatively scored. Scores decline as Wisconsin card sort categories deteriorates. And both of these measures reach their cut point at 2 sorts. So the exit reaches its cut point at 2 sorts or less, and CLOX 1 independently reaches its threshold for impairment 10 or 15 at the same number of category sorts. Here's the mini-mental. It declines with Wisconsin card sort, so it's related to Wisconsin card sort, but even the group with the worst performance still has a normal mini-mental score. So basically, the mini-mental is sensitive to executive function. It's just that its thresholds are set wrong for the detection of executive impairment. We've empirically determined that the best mini-mental score to detect executive impairment is 27. So basically, if you use the threshold of 24, 25, then you'll miss many executive impaired persons because many of them do not have Alzheimer's, and therefore the mini-mental is not detecting these sensitivities. So you have to throw the threshold up higher if you want to use the mini-mental or something like it for detecting executive function. So basically, the advantage of the CLOX and the exit is that they're bedside instruments that could be given in almost any clinical setting. They're sensitive to executive impairment across multiple diagnoses, and as I'll show you in a minute, they predict functional status. Okay, I'm going to do one more of these. We'll see where we go. Okay, so when it comes to functional status, I remind you that functional outcomes are goal-directed behaviors and therefore inherently vulnerable to executive impairment because you need the executive functions to achieve these sorts of complex, organized behavioral streams towards a goal. And executive function is metamodal. It controls everything. The frontal lobes act on information from all over the brain. So you can think of the executive control of dressing and grooming and shopping and finances. If you lose the practic elements of these, then you might lose one or the other. If you use the executive function, you lose the control of everything. See, so it's amplified, the effects of executive impairments, as opposed to other lesions in the brain that might affect these sorts of functional tasks. And it gets you twice. It gets you directly because you just can't do the job anymore. But it gets you indirectly by undermining compliance and your access to the healthcare services. Because in RVA, for example, to refill your prescriptions, you have to interact with a telephone automated refill system that requires executive function to interact with. So we've had patients that we've intervened on their executive function, improved it, then they run out of their pills, their executive function declines, and they can't effectively refill the prescription, and they come in 6 weeks later, totally having gotten off the wagon as far as their treatment, because once they ran out of pills, they couldn't interact with the healthcare system to get more pills. I'm just about to publish, this is still in press, a systematic review of the cognitive correlates of functional outcomes. We found every published multivariate model that was a cognitive predictor of a functional outcome, and then just applied some simple statistics to these. We came up with 68 papers that had these sorts of models, 50% were in the geriatric literature, 40% were in the neuropsychiatry literature, and these papers in their aggregate led 156 different multivariate regression models that had a cognitive correlate of a functional outcome. And we looked at the total variance attributable to cognition and the unique variance attributable to the individual measures that made these models. This is a distribution of So in general, cognition is not a great predictor of functional status in the sense that it doesn't explain a lot of variance. Here are the amount of variance specifically attributable to about 30 different memory tests. On average, the amount of variance that memory independently contributes to a functional status is less than 3% of variance. And most of these are exactly zero, meaning that they did not contribute significantly to the model, so we assign them variance to zero, even independently of covariance. Here are 30 executive measures. What you can see here is that generally they do better, but not great. The average amount of variance in an executive measure, a putative executive measure, is, remember, very few of these tests were actually explicitly validated as executive measures. But is quite a bit bigger than memory. It's 7%, almost 10% on average. But there's wide variability within specific measures, and you'll notice the exit here is one of the best. It averages in 12 papers comprising over 800 subjects. On average, it enters models and explains 25% of the observed variance in whichever functional status is being made in the model. And that's why the error is, there's so many of these models published now that the error in incompetency is very small compared to other measures. It may be one study achieved a similar explanatory power, but it was only one study, so it's a much wider. The exit specifically is significantly better at predicting functional status than a variety of commonly used general measures, including something like the Madison Rating Scale, initiation perseveration subscale, which is widely, by consensus, thought to measure executive function, although I'm not sure it's ever been validated for that. People say that measures executive function. So in summary, cognition is really relatively modestly associated with functional outcome, and the domain most strongly related to functional outcome is going to be executive function. And even within that domain, there's wide variability across individual putative executive measures. And what the exit offers you is something that's been studied much more completely, I would say, than other executive measures, particularly vis-a-vis its ability to predict functional outcomes. And there's a huge literature on the Stroop or train making or Wisconsin card sort, but those measures have rarely been used to predict functional status because essentially many of them are impractical for that. So you just can't get 3,000 people in a community sample to take those kinds of things. Now, we've been doing this most explicitly in this retirement community. I told you about the Air Force villages, and I just thought I'd give you a picture to see how it works. In San Antonio, we have these entities called Comprehensive Care Retirement Communities, or CCRCs, where every level of care, from independent living to dementia-specific care, is given to patients in a single campus. So no one ever leaves the system because they need different services. They're not discharged and sent off somewhere. So generally, these people are highly educated, affluent. In the Air Force Villages case, in particular, they're retired Air Force generals and their dependents. And they come in generally in good health in their 60s, and they're in these independent living apartments. But then over time, they need to go to congregate high-rises here. And then from there, they may move into a nursing home. And then from a nursing home, they may or may not move to a dementia-specific care unit. And so we can model these transitions in the same cohort longitudinally over time and develop multivariate models of the high importance of these transitions in care. And cross-sectionally, this is a different retirement community, but a similar one. Cross-sectionally, executive function is relatively strong. This is the variance in level of care explained in exit relative in multivariate model to the number of medicines, mental, physical, comorbid medical conditions, age, problem behavior, and education. And this is Air Force Village data, cross-sectional data in terms of individual instrumental activities of daily living. After adjusting for mental, the exit still takes all these IDLs after adjusting for, that's cross-sectional. And each of those individual domains has a relationship kind of like this. Here's the exit scores in red, and 15 is its cut point. here's medication usage. It's the same relationship again. So in multivariate models, here's, again, a different retirement community, but similar to Rivers Villages. It's a multivariate model adjusting for age, gender, and whether they live alone or not in their apartment, and only the executive measures enter the model. And CLOX enters independent of the exit. It's not quite exactly the same as using the exit. So it adds some additional information. But independent of the executive function, neither the mini-mental nor visual spatial praxis adds any further variance to this model of level care. Here's the study I referred to earlier from England. This is a study of 30 inhibitor-naive inpatients with an average age of 85 and normal, essentially abbreviated mini-mental scores. And then they received standardized training on using a meter dose inhaler, and they were also screened by different observers on the basis of their exit mini-mental scores. Both the exit and the mini-mental were associated with a test they had to take the next day with their capacity of what they had learned from this training session. The mini-mental correctly classified 18 of 19 competent patients, but it missed some of the incompetence. The exit, though, was perfectly associated with the capacity to learn to use it. Now, all of that's cross-sectional data, but we've been following our retirement community cohort longitudinally in time. And so, over time, exit scores get worse, and by the third follow-up, which would have been 3 years after the initiation of the cohort in this slide, the entire cohort now has a mean in the impaired range on the exit. So over time, this cohort is succumbing to incremental increases in exit scores leading to failure on average. The mini-mental declines too, but over the same course of time, despite the fact that their exit scores are getting worse and now the cohort as a whole is failing, the mini-mental scores are still in the normal range. So the mini-mental is relatively insensitive cross-sectionally and now longitudinally to some process that is destroying the executive control of these healthy, independent living 70-year-olds over time.
What time?
3 years. Yes, 3 years. Anyway, but means are one thing. The truth is actually in the variability of individuals as they course over time in terms of their score. So we can describe this statistically in terms of the intercept of the slope, the average rate of change in the slope, the variability about the baseline intercept, and the variability about the slopes over time. And we do this through what we call growth curve models. So here's a growth curve model that we published in 2004 of baseline IEL, age, level of care, comorbid disease, baseline exit, and change in exit as predictors of change in IEL over time. And what this shows you is that the exit is this change in exit is the strongest predictor of change in IEL, independently of baseline IEL and even baseline exit. We did a similar model for the mini-mental, and change in the mini-mental cannot predict change in IEL independently of baseline mini-mental and the exit. Here's another one. This is a more complicated multivariate model now in the same cohort, the Air Force Villages, of change in memory on the California Verbal Learning Test as a predictor of the rate of change in IEL relative to the exit after adjusting for baseline level of care, age, comorbid disease, and baseline IEL. So independently of these covariates, the slope of change in the exit, again, significantly explains the slope of change in IEL. So it's about 25% variance. But the slope of change in memory has no independent effect on change in IEL. So once again, a memory measure now, a formal memory measure, is not a core liver function status. It's actually the executive impairment simultaneously evolving in the same subjects that explains the disability. We had a similar model, we've never published this, of the change in the Wisconsin card sort. Again, independently of the exit, Wisconsin card sort slope has no independent effect on the slope of change in IEL. Here's another model that we've published. This is kind of interesting. This is an attempt to use what's called a decision-making tree. This is not, it's quasi-statistical. It's basically computers trying to find the best combination of screening measures that would allow a nurse to classify a patient's level of care on admission to the retirement community. We're trying to help the retirement community correctly position people in the system when they first are admitted. And so we chose only things that the nurse could do at baseline. In other words, we had other variables that we could have used for this model that would have been practical to final algorithm. So we just chose things that the nurses could do at the baseline. And the model correctly classified the level of care of 78%. It wasn't a total success as a predictor model. But it did pretty good given that the nurses now making this decision instead of a formal triaging process. Anyway, but what this model allows you to do is look at the relative importance of each of these potential screening variables for their ability to distinguish the level of care in the retirement community. Age is the strongest, the most important one. In this model, CLOX-1 is the next, and then the exit after that. And these two are much stronger than, say, Mini-Mill, CLOX-2, or even some of these other computed executive tests, trail making, verbal fluency, or the max dementia rating scale, memory subscale is the weakest for its ability to distinguish this level of care. And this is the actual algorithm here. And what's interesting with this, although I don't think that you can see it from the back, but basically, this is completely automated. The computer is picking from the data the best variables that achieve the most accurate classification and the best thresholds for those variables. And the computer, independently of us, came up with the same thresholds that we've chosen empirically from other data sets. And so the computer chose an exit score of 15 or less to triage people most conveniently into whether they're at risk for a higher level of care or can they just go straight to inventor. And then, having already chosen the exit score, then CLOX-1 is the next test, and it empirically replicates its threshold point. So, in other words, this is validating our approach to setting the thresholds of these measures. So, executive function associated with disability and functional status, whether we're talking about longitudinally or cross-sectionally, whether we're talking about self-reported IDL or performance-based functional assessments, whether we're talking about medication type behaviors or things more complex like decision-making, which is actually the next review. I kind of feel like we should take a little break for this. And that we're only sensitively describing a neocortical dementia that is most commonly due to Alzheimer's disease, but we're letting that prejudice the way we think about dementia. And my position would be that, what makes cognitive impairment dementing is its ability to predict functional status. And so only cognitive functions that can enter a multivariate model of functional status and contribute to that model should be considered as candidates for, they're asking for more volume, Mark, and I don't have a volume. Mark, they're asking for more volume, and I don't have a controller. So basically, I would argue that what makes a cognitive function potentially a candidate for dementia-defined and cognitive impairment would be its ability to affect functional outcomes. And so if you build multivariate cognitive models of functional status, then the measures of the domains that enter those models should be considered the essential features of dementia. And dementia conditions would probably all share those fundamental cognitive domains. In the models that we've built, executive function appears to be the essential feature of dementia. And that makes me think that in Alzheimer's disease, the association with memory loss is just an artifact of the way the tangles spread through the brain, which ensures that if your executive impairment is due to Alzheimer's pathology, you will already have hippocampal pathology and therefore be forgetful. But it's not forgetfulness that makes you disabled, and therefore it's not forgetfulness that makes you demented. And it's the exceptions that prove that rule because so many other non-Alzheimer's conditions are capable of causing disability and dementia, even in the absence of impaired memory. It's just that the way dementia is defined right now, we can't code them as an entity. So there's a very strong selection bias against the recognition of executive function as a dementia-defining condition. So the situation basically I described for you in the background is that there are going to be many cases out here who have isolated executive impairment and yet are able to pass traditional screening measures, like the mini-mental. And this is because these tests, like the mini-mental, but really the mini-mental is the godfather of all cognitive screening measures. The VasCog that's used in clinical trials is really just to glorify mini-mental. Other studies, like the Women's Health Initiative study, use the 3MS, which is another expanded mini-mental. The Honolulu Asia Aging study uses the Cognitive Ability Screening Instrument, which is just another modified mini-mental. Essentially, all of these measures share the inherent insensitivity to executive function because they were never designed to do that. And so much of our dementia literature is blind to the executive impairments, even in the control groups. And what we're finding is that 28-30% of control groups with normal mini-mental scores have executive impairment on the exit and are functionally disabled by that. So just to give you a sense of how widespread this is, here are exit scores. Remember, high scores are bad. Anything over 15 is considered failing for 4 groups. These are normals, but these are children between the ages of 6 and 11. The frontal lobes are the last part of the brain to develop, so children don't have good executive function. They're irritable, they have temper tantrums, they have no sense of the picture, the plan. They get lost in the middle of things, they suffer intrusions, they're disinhibited. They have many signs of frontal lobe brain damage in adults because they haven't really completed their normal frontal lobe development. Here are young adults in their 20s. Here are 100 type 2 diabetics from our VA medical outpatient clinic. And here are 450 70-year-olds in independent living in a retirement community. So, is it more interesting to think that 50-year-old diabetics have the executive function of children, or that 50-year-old diabetics have the executive function of 80-year-olds? So this is very widespread. There are large fractions of the patients that we take care of who have debilitating levels of executive impairment. Nonetheless, the mini-mentals of the well elderly are generally normal because, like I said, you wouldn't fail a mini-mental from Alzheimer's disease until that process reached the neocortex, and that's actually only a minority of people over the age of 70. Most people over the age of 70 have tangles in their brain, but it isn't necessarily in the neocortex yet, and it particularly isn't in the frontal lobes yet, so they would pass the mini-mental. Anyway, so here's 609 well elderly from the very first Freedom House study. So the correlation between the mini-mental and the exit, the correlation is significant, but only moderate, 0.45. But what I want to show you is this box here. Everybody in this box A has failed the exit at 15, but has a normal mini-mental. And that was approximately 28% of the sample at baseline. Over time, we've given the exit and mini-mental to thousands of people, and so we've developed regression lines for the 2 syndromes based on our just anecdotal clinical experience. And so here's the regression line for cortical dementia in a mini-mental exit scatter plot versus type 2 dementia. And you can see that they don't even touch. They're 2 different syndromes. What this effectively means is that at any exit score, which predicts functional status, remember in multivariate models, the mini-mental doesn't predict functional status independently of the exit. So the exit is determining your level of care. At any particular level of care, let's take 25. This would be the average exit score for nursing home residents. So an Alzheimer's patient with an exit of 25 who has cortical dementia would have a mini-mental below 18 on average. They have a mini-mental of about 17 and be living in the nursing home. But the other syndrome at the very same exit score has a mini-mental of 23 and would be thought of as maybe mild cognitive impairment or the exit predicts the functional status, not the mental. And so basically, this is why I get mad at people thinking about things as dysexecutive MCI. The whole idea of MCI is that you're not disabled. If executive impairment explains your disability, then how can you be executively impaired and yet not disabled? And I think what happens is people just don't measure functional status. When they diagnose MCI, they do it based on clinical. They just sort of look at them and say, oh, I think he's normal. But they don't actually measure anything. If you actually measure stuff, then you would find that it's an oxymoron. People are disabled at exit scores. And even though their name is normal and they have no memory loss, they don't have mild anything. They're demented. They have a cognitive disorder that is disabled. And it just takes measuring it explicitly and putting that in the model. So because of this, because I think there's a pervasive bias that forces dementia to be channeled towards Alzheimer's disease, that's represented in the very way that dementia is coded and defined by traditional criteria like the UNIS variance criteria or the DSM, then in my research I've avoided using those descriptions because they basically would force me towards recruiting Alzheimer's patients into our samples effectively and would constrain the way people can think of this. But here I showed you the translation study, validation study that Chan did of a Mandarin Chinese translation of the exit. He included the CDR. Right? And so he has the Chinese exit, the Chinese mini-mental, and he gives you their means for each stage of the CDR. Now the CDR, the Clinical Dementia Rating Scale, is another instrument that I think is greatly biased towards the features of one of the syndromes, type 1 dementia, at the expense of the other. So for the CDR, to get a 0.5, you have to already have memory loss before disability, before dementia. Well, that is a manifestation of neocortical damage in neurofibrillary tangles. That happens in Alzheimer's. You use your memory before executive function as an artifact of how the tangles progress. But if you didn't have Alzheimer's, why would you expect memory loss to go first? There's no a priori reason why memory or the hippocampus would have to be affected before function if the disease was not related to a hierarchically evolving tauopathy in time. You see? So the CDR, its coding system is prejudiced towards one disease and tries to force other diseases into that nomenclature. So I never used it, but he did. And so here are the exit means for each increasing CDR score. 6.3 is within the range that we would see in normal young adults. 11 is close to the mean for elderly 80-year-olds in our retirement community and independent living. 18, the CDR1, is almost exactly the mean for assisted living residents in our retirement community. And 24 is the mean for nursing home residents in our retirement community. So the CDR rubric is picking up functionally distinct levels of executive function, and in fact the exit could distinguish these four levels of care. But if you map them into our historical means, you can see that the CDR is describing cortical dementia. If you map the mean on the exit, and it's not detecting the other syndromes. So the CDR is effectively biased towards one of the two syndromes and is grossly underestimating the prevalence, existence, and severity of the other syndrome. So in other words, the CDR is not a dementia staging instrument, it's a neocortical type 1 dementia staging instrument. You see, it's predicting one disease, one dementia syndrome, not both. So in the interest of time, I'll skip over these slides because you've seen them before. I just wanted to give you an estimate of the prevalence of these two syndromes in well elderly persons in our retirement community. We developed a discriminant model. We had no other way to classify these at first. So we developed a discriminant model based on the exit, the mini-mental, and clock drawing. So 3 bedside instruments that would be easy to obtain. And then we taught the model to distinguish 3 well-documented groups. One group had uncomplicated Alzheimer's. The other group had uncomplicated subcortical vascular disease with no cortical strokes. And the third group were young adults, not even elderly. Okay, young adults. And we taught the model to distinguish those three groups on the basis of the mini-mental, the exit, and the CLOX. The final model was about 78% accurate against our original independent classifications. And then, once we had the the discriminant model, we could identify the dementia type in unknown groups given the same measures. And so what we did was have the model tell us which dementia syndrome patients with, say, diabetes were presenting with. And it turned out the model classified diabetes as type 2 dementia, vascular dementia. We had to do HIV, same thing. We had to do major depression, same thing. We had to do Lewy body, they call it a cortical dementia. So basically, this was our empirical approach to this. So we use this discriminant model to determine whether well-elderly persons in independent living or retirement community were young adults, vascular dementia, or Alzheimer's. And it basically said that the majority of them, depending on their age, were type 2 dementias. In other words, normal aging leads to executive impairment. It's statistically normal in old age to have executive impairment. It's not statistically normal in old age to have cortical dementia. So, but it is normal to have executive impairment, and that's the other dementia syndrome. So, basically, I think that normal aging through some mechanism that has not been described because people haven't done the research yet to identify the mechanisms that mediate executive impairment and normal aging. But aging itself is associated with longitudinal increases in executive function over time that are not part of a global limiting process affecting other cognitive domains. It's specifically executive function that's being undermined here. Now, at this point, I'm going to do this here. So let me just make sure. I don't want to steal everybody's thunder here. Okay, so what I want to do now is show you that it's very important to identify these type 2 cases because they're easier to treat than we're generally used to. And I'll show you, we've been systematically for the last 2 years, we've been trying to probe the current pharmacology to find measures that may be active against executive impairments, specifically in the context of type 2 dementias. And one of the first things that we had noticed, anecdotally, I published this figure in like 1996, 1997, is that Zoloft, or sertraline, and by way of disclosure, I'll mention that sertraline's generic now. But anyway, I don't work for anybody or give talks about it, so Zoloft is just what we've been using recently in clinic. So basically, we noticed, in a large fraction of our cases that we were treating for depressive symptoms, what people might call vascular depression, I guess nowadays, that executive function can respond to sertraline, particularly higher doses. So here's an elderly gentleman, and he's 80 years old, depressed, treated with sertraline 100 milligrams a day. He comes in with a mini-mill of 27 out of 30. So if you had screened him for dementia with a mini-mill, he would have said he had no cognitive impairment. You wouldn't even worry about MCI with a mini-mill as high as 27. But his exit, 23 out of 50, is the average for nursing home residents for 6-year-old children. He can't draw a clock on CLOX1, but he can copy 10. Pentagon's fine, mini-mill. That's a copying task that isn't very executively demanding. After only a week of therapy, his exit was dropped to 18, the average for assisted living, and his CLOX is improved. And after 2 weeks of treatment, his CLOX and exit are normal. All the way back from the mean for nursing home residents to normal in 2 weeks. But the mini-mill didn't detect any change. So if you screen for dementia then you would have said he had no cognitive impairment at the beginning and that this drug had no effect on cognition over time. So we have a clinic called Memory 2, where we triage our patients who have type 2 dementias. And effectively, the only way that we screen them is that we want their mini-mental to be normal and they fail the exit. So this memory clinic supplies a wide variety of regional primary care physicians, and if they think their patient may have memory impairment or some cognitive impairment, then they'll refer them to us. We pre-screen them to get rid of cases with affective disorder or psychosis, and we give them the mini-mental and the exit. The cortical cases we leave in the memory clinic, and the type 2s we move over to Gen Memory 2. And so in this clinic, residents do the exit, the mini-mental, GDS, CLOX at every visit. And we use semi-structured off-label treatment guidelines, essentially an algorithm, because we're probing every part of the frontal circuit. I showed you the circuit. I showed you the valences of the different neurotransmitters. In animals, it's been worked out exactly which neurotransmitters are involved in each step of the circuit. So basically, we're probing each of the neurotransmitters where there are drugs available and trying every possible permutation of drugs to try to get the frontal circuit to come back online, because we don't believe that these cases have structural frontal cortical brain disease. Our target instant outcome is the exit. We want the exit score to improve. A priori, we define meaningful improvement as more than 3 exit points. That would be half of the distance between any 2 retirement communities. Retirement communities each point any 2 levels of care in the retirement community. Each level of care is separated by about 7 exit points. So 3 is about half of the way between 2 different levels. And we define complete resolution as achieving an exit score of less than 15. So it just turns out that we're starting to analyze this data, and the first drug in the algorithm is sertraline. That's the one we lead with. So as far as sertraline goes, we treat them up to 200 milligrams a day. And if that fails, then we may switch them to another drug. Usually these are dopamine reuptake inhibitors. That's because we think sertraline is acting. Sertraline is a dopamine reuptake inhibitor as well as a serotonin reuptake inhibitor. So we're taking advantage of that property here, which is why the dose has to be so high. And if sertraline or one of these other ones alone doesn't work, then we switch to atomoxetine and nimotine, and then if that doesn't work, we take the atomoxetine away and try nimotine alone. If that doesn't work, we add back one of the SSRIs, and if that combination doesn't work, then we give them the GABAergic anticonvulsants. Take the best drug, farm it off for clinical trial pilot studies. Take the worst drug, kick it off the algorithm, add 2 more drugs, and reiterate the whole process again for another year. So generally, we have a baseline visit where the first drug in this year's with the data was sertraline. So we started at 25 to 50 milligrams, titrated up towards 100, and have them come back after 4 weeks on 100, so 6 weeks after the initiation. Then we assess them on 100. If that didn't work, we go up to 150. Remember, our target is a cure, so they may achieve partial improvement, but we want them to be normal in the exit. So we keep going if we don't achieve that. If 150 didn't work, we'll go to 200 by visit 2 on general. If on visit 3, we're generally at the highest dose that they'll tolerate. If that didn't work, we may go to the next step in the algorithm. And so the outcomes available are visit 3, which generally is the highest dose. First exam on 100, first exam on 150, the maximum dose, no matter what it was, or which visit that was at, and the best exit achieved regardless of what visit or dose that was. Okay, so here's the sort of patients we're finding. Here, these are 30 consecutive sertraline trials. So, the average exit score is impaired at 23. That would be close to the mean for nursing home residents. The average mini-mental is still normal at 24. They're impaired again on CLOX 1 on average, below 10, but they pass CLOX 2, and the GDS is also not in its impaired range. This is our clinic and where we can put them, as opposed to, like I say, the type 1 dementia bias, traditional dementia screening. In terms of their exit, our sample is at a CDR of 1. But in terms of their mini-mental, our sample is at a CDR of 0.5. So you can see how this works. If you use the CDR to decide who is MCI, then they can be disimpaired. They can be disimpaired executively as frankly demented cases. If you use the mini-mental or the CDR at this stage. And just for comparison, to show you how this works, here are the exit and mini-mental scores for a recently completed study of vascular dementia, where the authors were very stringent about operationally defining dementia according to the NINDS criteria. But because those criteria themselves are biased towards cortical dementia, even though these authors think they're treating executive impairment due to vascular disease, I think they're treating executive impairment due to subclinical, unimageable Alzheimer's biology. And it's an artifact of the case definition, right? Our sample is clearly really different than what gets into the traditional dementia literature. Nonetheless, even though the only criteria for putting these people in this clinic was that they had a normal female and a bad exit, 87% have hypertension, 40% have diabetes, 27% have a self-reported history of TIA or stroke, 40% have heart disease, 10% had heart failure or a past cabbage operation, 61% had hypercholesterolemia, were being treated for hypercholesterolemia. 61% on MRI had a structural lacunar lesion, 30% had white matter lesions, 26% had ventriculomegaly, and only 17% had a normal MRI. Now, we didn't select them for vascular dementia. We selected them for type 2 dementia, and this is what you get. What you get are people with prominent frontal system vascular disease on their imaging and prominent vascular risk factors in their medical history. Also, here are their medications. We thought that we might find a lot of insulin. We have other data that suggests that exit scores in diabetics are strongly related to hypoglycemia. But this is really interesting. Every one of the cases that I showed you who had normal MRIs were on a beta blocker, even though beta blockers were only being used in 4% of the studies. Everyone who had type 2 dementia without vascular disease on their MRI was being treated by a beta blocker. Another really interesting thing is the B12 level. Even though the mean level is normal, 30% of the cases have a B12 level less than 180. In other words, this dementia case definition enriches the fraction of cases who have clinically significant B12 deficiency. Another interesting thing is 13% had anemia, and there's a clinical trial of anemia of chronic, post-chemotherapy anemia being treated with Procrit, where they use the exit as a secondary outcome, and Procrit had a significant effect on exit scores in anemia cancer patients. So anemia may be another mediator of executive impairment in medical patients. Here are some of our treatment responses to just give you a flavor of this. This is an 80-year-old with vascular disease, treated with surgery 150 milligrams a day. He comes in with a mid-mental of 29 and an exit of 26, again near the mean for nursing home residents. 2 months later, when he comes back probably for his first visit, his CLOX is better. His exit has dropped from the mean for nursing home to close to a little bit below the mean for assisted living, and only 1 point away from normal. The mini-mental improvement point. Remember, we're not treating depression. These people don't have depression. Here's another one. Mini-mental 25, exit 32, dementia-specific care units. He comes in with a drop to the equivalent of nursing home residents, so 1 level of care, despite the fact that his mini-mental is normal in both sessions. Here's another one. This one may have some Alzheimer's mixed in, because notice the mini-mental detects it. He's 19 out of 30 on the mini-mental at this point. The exit is 18 over 50. That's the mean for assisted living. After sertraline, his exit drops to 14, achieves complete complete remission according to our criteria. His mini-mental doesn't really change very much. Here's another one. This is just to tell you that it doesn't have to be sertraline. There are some other drugs that may be able to do this. He's treated this case with venlafaxine. His exit goes from 26 to 13, achieves complete remission. His cognition improves. So, to summarize these cases, the mean maximum dose we achieved was 136 milligrams a day. The range was 50 to 200. The mean change in exit from baseline to best score at any dose was almost 6 points, which doesn't sound like a lot, but that's about the distance between any two levels of care in the retirement community, and it's specifically 3 times bigger than the effect of galantamine in a study of vascular dementia cases, where they use the exit as a secondary outcome study. And in Pfizer's recently completed study of Dementia in vascular dementia, where they used again the exit as a secondary outcome, Aricept had no effect on the exit. And yet sertraline, which is a generic medication, is achieving 6 points. Of course, this is all open label, right? This is placebo control. The heart, 26 patients improved. That's 87% of the sample. That means they achieved at least 3 points, and 56% achieved meaningful improvement. 33% achieved complete resolution of their executive impairment. Only 1 had a worsened exit score. And it looks to us like 150 milligrams was the best dose. Some people we would go to 200, but we hardly ever salvaged them, and some of them had more side effects. And interestingly, even though the exit's getting better, there's no improvement on the GDS. Even though this is a really small sample, we have statistically significant effects for the 150 milligram dose and baseline versus the best exit. The maximal dose here didn't achieve significance, and what's interesting about that is, of course, if we push them to maximal, that includes people who were true failures, and we're pushing them up, even to 200, and they did it better. And the GDS had no effect. Here is baseline. We have an exit score near the mean for nursing home residents versus the mean at 150, the first visit we were on 150. So that's essentially 1 level of care in the retirement community. Here's visit 3, no matter what dose they're at that visit, again, improving. Here's the maximum exit dose at any visit. Here's the best exit with the best separation from baseline versus the test response at any dose. Here are the GDS scores. The GDS is improving here, but our rationale for doing this with sertraline is that it's a dopamine reuptake inhibitor. It's not as potent against dopamine as it is against serotonin, but nonetheless, it's half as potent as amphetamine and twice as potent as Wellbutrin or bupropion as a dopamine reuptake inhibitor. So that's the property that we think we're taking advantage of here. Anyway, in fact, we do see psychosis, especially at higher sertraline doses. So far, this has only been in the auditory realm and responds immediately to dose reduction. We've seen EPS, we've seen dyskinesias, we've seen the most common side effect that we found were sleep disturbances, sometimes insomnia, sometimes somnolence, and interestingly, we never had any GI side effects, despite the high doses that we're using. So, in general, it looks like sertraline can improve executive function. This is especially true in in vascular, but also I think maybe in the vascular dominant mixed cases, which are also very common. In other words, there may be people who have Alzheimer's pathology in the hippocampus already. So they have memory deficits that won't respond to category prompts, for example. But nonetheless, they don't have a Rock stage greater than 4, and there probably isn't the cortical, especially Doses generally to do this had to be over 150. The effect size is between 4 and 10 exit points, but that would give you a level of care back, and it's much bigger than what we've seen with cholinesterase inhibitors. And occasionally, we take it it's completely reversed. But sometimes it's dramatic. People just come back and they're normal, and the family is just very excited. That's not always, but and we don't understand yet what makes a person respond like that. But sometimes it's very dramatic, and they're just fixed. So at this point, I think I'd like to hand the podium over to Dr. Dakota and have him come and share with you some of his experiences in primary care using the advent of CLOX to inform their decision making. But before he comes up, maybe we have a microphone here if there are people who would like to ask any particular questions.